Good morning, Chairman Tiberi and Senator Hassan. Thank you for inviting me to participate in this discussion of the opioid epidemic that's plaguing our nation. Just over 33,000 people died in 2015 from opioid overdoses. In the time I have with you today, I want to focus on the gap between the need for treatment and the receipt of care. In 2015, there was an estimated 2.66 million people with an opioid use disorder in the country. The illness is concentrated in the low-income population. That is, 51% of people with an opioid use disorder, or OUD, have incomes below 200% of the federal poverty line. Only 26% of the people with an OUD receive treatment for that disorder. That means that 1.97 million people who needed care did not get it. This is tragic because there are treatments that work. Medication-assisted treatment has been shown to be the most effective treatment for OUDs. They are combinations of pharmaceuticals, psychotherapy or counseling, and drug testing to monitor treatment adherence. Now, national survey data show that over half the people that did not get treatment because they either couldn't afford it or there were no providers available. Other reasons for not getting care were not being ready to stop using substances, stigma, and the denial of the problem. Now, policy tools are most amenable for addressing the affordability and availability reasons. I will focus on three areas that are helping to make the treatment gap smaller. They are Medicaid, private insurance, and federal grants. Medicaid covers about 34% of people with an OUD. Recent policy changes in Medicaid have bolstered Medicaid's impact. The combination of the Mental Health Parity and Addiction Equity Act that requires comparable coverage for mental health and substance abuse disorders with medical surgical care, the Medicaid expansions, and the essential health benefit that includes substance abuse treatment all have driven Medicaid to a growing role. Together, these provisions have resulted in large increases in the use of medication-assisted treatment. A number of states have been using Medicaid as a central part of their attack on the opioid epidemic. The state of Ohio recently reported substantial increases in access to care for people with opioid use disorder. And in Ohio, Medicaid now pays for nearly half of all the buprenorphine prescriptions in that state, which is one of the key drugs in medication-assisted treatment. Let me now turn to private insurance. Private insurance covers about 42% of people with an opioid use disorder. Recent changes there have bolstered the ability of private insurance to shrink the treatment gap. They are the Parity Act applied to private insurance, the essential health benefit provisions in the small group and individual market, and the availability of subsidized insurance policies for low income. In 2011, a survey of individual market insurers revealed that 34% of policies sold did not cover substance use disorders. Today, that is no longer the case. Finally, grants to states. The recently enacted 21st Century Cures Act appropriated $1 billion over 2 years that was intended to focus on closing the treatment gap by expanding capacity and expanding direct treatment. Just under $500 million of that money has been recently allocated to the states. Let me take a moment to put the Cures money into context using the state of Kentucky's experience. Kentucky is receiving a grant of about $10.5 million under Cures. That buys about 1,900 full-year treatments with medication-assisted treatment. Currently, Medicaid pays for 4,200 person-years of treatment in Kentucky, and 3/4 of that is for the expansion population. That means if Medicaid cuts of the magnitude proposed occur, the Cures funds would likely not be used to expand capacity and treatment, but would instead backfill for Medicaid losses and wouldn't even be able to cover 2/3 of those. I now touch on availability. Since policy changes that I've described have begun, there's been a surge of new private money into this sector. There have been 170 private equity deals between 2012 and 2015, some as large as $100 million. These private investments are aimed at scaling up evidence-based practices, and the investment community acknowledges it is directly linked to the flow of new funds, both on the private and the public sides. So the last 10 years have set a platform for closing the treatment gap. The evidence suggests we are starting to see important expansions in both capacity and treatment that will pay dividends in the future. Turning back now doesn't make either economic sense and likely leads to tragic consequences. Thank you.